Okay, we're ready for our next case, and this is going to be challenging. Uh, we've actually cleared out the stomach of residual fluid. It's now fairly empty. This is a 61-year-old female with a history of a malignant neuroendocrine tumor of the pancreas. It was diagnosed actually 17 years ago in 1998, and she has undergone various regimens of chemotherapy and radiation therapy. There's been some shrinkage of her tumor, but about 2 years ago, just over 2 years ago, she developed gastric outlet obstruction. And she had stenosis of the duodenum, and a metal stent was placed, a duodenal stent was placed, uncovered, of course. And a year later, she presented back with recurrent gastric outlet obstruction as well as bleeding. And so a second metal stent was placed inside of the first one. And now she presents about a year later again with recurrent gastric outlet obstruction. That's her main complaint. She's losing weight, nausea, and vomiting. And now you're looking endoscopically at the duodenum, and you can see it's just completely blocked here. I don't think there's any lumen to be found. I can irrigate a little bit of with some water to see if we can flesh out some of the. There is a little bit of blood clot here as well, but I think most of this is ingrowth, tumor ingrowth of the duodenum. And let me just kind of pull back. Here on the side, on the right-hand side, you can see the metal stent, the bare wires, and the stent has been almost circumferentially ingrown. So it's embedded in the duodenal wall. For that matter, it may actually be outside of the duodenal wall now. So you can see that on the left-hand side, it's completely overgrown. On the right-hand side, you can see the stent wires, the mesh. If we kind of pull back a little bit further, so here we are in the proximal duodenum. Let's pop in one more time. Here's the, this is the antrum. This is the pylorus. You don't really see the pylorus well. Let me just pull back just a little bit more. Yeah, so there's the pylorus, and it's patulous, it's wide open, and now we go into the bulb here, and we start to encounter pretty much at the apex already the obstruction. And there you can see tumor tissue, right? The whitish tissue here. Now, we can certainly see if we can feed a guide wire across this obstruction. I'm very doubtful that that will be successful. It would be nice to be able to feed a wire across because then we can place a catheter to, there you see the tumor very nicely now, the whitish tumor tissue obstructing. It would be nice to be able to infuse water into the downstream duodenum, which would allow us on endoscopic ultrasound to see the duodenum better, or the distal duodenum, for placement of our lumen-opposing stent to create a gastrojejunostomy. That may not work though. So let's just try with let's use a glide wire, and let's give it a try and see if we can get it to go across. You probably don't want to use a stiffer wire because it's likely to cause A, a lot of trauma, B, it could actually create a false path. We don't want to do that. So I think a glide wire would be the best choice here. There's a possibility that it may find the path, but I'm doubtful. This really looks like it's lumen occlusive. But for the sake of the exercise, we'll do it. We're all leaded in the room. We're hoping not to use any fluoro during this procedure, but in case we do need to use fluoro, we have it available. So we are in a fluoro room, and we're leaded as well. Okay, so I'm just advancing the glide wire forward. I'm not putting this through a catheter really because this is just an exercise to prove to you that we're not going to find a lumen. You can never push against resistance. So very gently. You see how the wire just backed up on itself? I'm just advancing very slowly. It's a rather blind. Now, I do feel that the wire is going someplace. Who knows where? So I think this is where it would be wise to use some fluoro. And yeah, it actually looks like it's following the C configuration, doesn't it? That's actually a stroke of luck that wire happened to follow the duodenal C. Let's bring it down a little bit so that we can see the duodenal. There we go. Excellent. So I'm going to push this in a little bit further. I'm very pleased that we're in the duodenum. It certainly looks like that. So let's follow this now with a catheter. So we're going to feed a catheter over the wire, and then we're going to inject a little bit of contrast. What's nice about doing this is that we'll be able to fill the downstream small bowel, the duodenum, distal duodenum, with water, and it's going to make it a lot easier for us to visualize our target for our gastrojejunostomy. Now, of course, we could place another metal stent through this. It could be a fully covered stent. I'm just very concerned that this is not going to give her sufficient relief of her gastric outlet obstruction, and there's because the lumen will be already. She's got 2 stents in there, right? And by placing a third stent, I don't think it's going to open up sufficiently for her to get at least the best quality of life that we can offer. And I think the best quality of life will be a enteric bypass, a gastrojejunostomy. And really, our backup here is to send her for surgery for a gastrojejunostomy. And we've already discussed that in the consent, that if this is not successful and the patient is an inpatient, this is not successful, or should we have any complication, our surgeons are available on backup to take her to surgery for a gastrojejunostomy. Okay, so let's, I'm just going to keep pushing the catheter down. Again, on the right, you can see the exposed mesh of the uncovered stent. Keep pulling back. Here we see our catheter coming. I'm going to keep advancing this, and I'll just kind of look on fluoro as well. See how my catheter, you can see the catheter is going down. Looks good. Now let's pull out the wire, and we are now going to inject contrast through our catheter to confirm that we are beyond the distal end of the stricture, of the tumor stricture. All right, so now we're going to inject some contrast. Okay, keep injecting. Keep injecting. All right, so now we'll take a look on our, there we go. And yes, indeed, we are nicely in the duodenum, this distal duodenum. You can see the ligament of Treitz there, right? Where it makes the curve, pulling back a little bit, pulling back. This looks really nice. So I think you're looking right there at the ligament of Treitz where it makes that bend. And so our catheter is in the 4th portion of the duodenum. All right, so this looks very good. Now, what we want to do is we want to leave this catheter in there so that we can continuously irrigate. The challenge, however, is how do we remove the scope, leaving the catheter in place? And the only way to do this is by cutting the catheter, and then we're going to attach our syringe directly to the catheter. There's no way right now that we can remove the scope, leaving the catheter in place without cutting the hub here. So we're going to have to cut here, but then we can use a needle to infuse water through this catheter. The other option would be, do we have something that has a removable hub? Or we can use a nasocystic catheter. Yeah. So actually, a better choice would be the nasocystic catheter. So why don't we go ahead and do that? we're going to switch this out for a nasal cystic catheter, but the first thing you need to do is put the wire back in. That's correct. So a nasal cystic catheter is good. And perhaps in hindsight, we could have started directly with the nasal cystic catheter rather than with a conventional ERCB catheter. But the drawback of using a nasal cystic catheter is that it's got the pigtail at the end that's going to deploy. So you're not going to have the same maneuverability. So I think this was a sound choice, starting with the ERCP catheter, confirming that we are downstream from the tumor stricture, and now switching out for the nasal cystic catheter. We will do an exchange now. No, I think you can leave the pigtail because the pigtail will give it a little bit of anchorage. I sort of like that. All right. Okay, let's take a look. It's just coiled up on itself. It's not a problem. Okay, we can look on the endo view. Keep pushing, please. We don't have to step on the fluoral the entire time. Let me just pull back just a little bit. Yeah. So here we're just using the endo view to guide our exchange. That wire that you see there is just coiled back because it's coiled back at the ligament of Treitz. You can push faster, Jeannie. Please keep pushing. And as long as you see that second coil that where it came back on itself, we're good. Because that'll start coming back first. All right, good. I'm going to hold the wire. And now, please. Okay, we're going to fix, this is a glide wire. So it's very important to make sure that you don't accidentally pull back the wire. It's so slippery that it easily pulls back. You easily lose the wire. So now we are feeding our pigtail. We've decided to leave the pigtail on because I actually think that will be helpful because it will help anchor that and it will also allow, I think, better irrigation capability because we've got irrigation through multiple side holes in addition to the end of the stent or the catheter. So filling the small bowel lumen is very important when accessing the distal duodenum with the AXIOS system. Flushing a little water through so that the catheter glides more easily. It's a snug fit because this is a diagnostic gastroscope with a 2.8 channel. All right, so now we're pushing down and, oh, careful. You just saw we lost the distal end, so just be careful that you don't pull back too much. And we should see the catheter in just a moment. There it is. Okay. And now we'll step on the fluoral to make sure that we are following. You can see right now everything's straightened out very nicely. You can see the outline of the stomach. You can see actually very nicely because we filled the stomach with air. You can see where we're going to create our GJ. I think you can appreciate that very nicely. That part of the distal duodenum that is in apposition, literally in apposition with the greater curvature of the antrum body transition. All right, so I think we're far enough in. Yes, we are. Okay, so now we can pull the wire out, and that should release our pigtail nicely, right? And it is. Good. Now we're ready to pull out. I'm just going to advance our catheter. This is no different than when we place a nasal cystic catheter for pseudocyst drainage, for example. I'm pushing in, and I want to get some of this air out as we're doing this, although I can take it out later. There's not much room in the working channel, so we're not getting a great aspiration effect here. So I'm coming out, and as soon as I'm out, we're going to go alongside the nasal cystic catheter. There we go. With our echo endoscope. We're going to switch out for the echo endoscope now. This is the therapeutic channel echo endoscope. It has a 3.7 millimeter channel, curved linear array. So remember, this is oblique viewing. Advancing very gently. This is a larger diameter scope, so you need to be more cautious. Our nurse is holding the nasal cystic catheter in place. It's technically a nasobiliary catheter, and there's certainly no cyst. We're not in really the bile duct. So what do we call this? The nasoluminal catheter would be the proper name. But on the package insert, of course, it's a nasobiliary catheter. That's what this was designed for. All right, so here we are, and we're in the stomach. There's no need to go further down. We're just going to take out air, and we're going to switch to the EOS image. All right, now we're going to look for the loop of bowel, and we're going to help ourselves by putting some water. And you can see a loop of bowel right now with air in it, filled with a lot of air. And I wonder if that's the good position. And because this is where actually I have to say X-ray is not bad, having it's available to just sort of confirm position. So let's now first, okay, good. So we have our, just to show you, we have our nasal luminal catheter, correct? We have this now hooked up to a water pump, so I can just step on the pedal and I can infuse water into the small bowel. And just for the sake of instruction here, demonstration, why don't we just take a quick look at the fluoral image to see about where we are. Okay, that's a bit of a different position. You'd think that and it's a good thing that we had our pigtail on, because you can see that our nasal luminal catheter has come back a little bit, right? But that's okay. I think we're still good. And it's not that we need to puncture where we see the catheter. Why don't we start putting water in? So I'm going to press on the pedal now, the water pedal, and see if that starts to displace some of the air in the small bowel here. Interesting. Here's where it's filling, not here. So this is actually a neighboring loop of bowel, probably further down, jejunum, right? And this here that we're filling with the water, very nice. This is the distal duodenum. There, we see it nicely. We see the Kirk-Crane folds here. It's very classic small bowel. So let's find the best spot to create our gastrojejunostomy. And of course, there's going to be some peristalsis here. And why don't we give some glucagon? I think it's not a bad idea to give a little bit of glucagon. Now you can see there's another loop of bowel down here. But what we want to go for is the loop of bowel that is immediately adjacent to the stomach wall. And that would be, here's the muscularis propria of the stomach. Here is the loop of duodenum. And let's just sort of look with fluoro just so we know about where we are. So let's have a small fluoro image, or you can make it large. Very nice, very nice. You can see there's contrast. Somehow we got contrast. Did you put some contrast in the water, or I wonder how we're getting contrast in there?
Maybe the residual.
Residual, yeah. Okay, good. So what our nurses are going to do is this is the Hot AXIOS, so it has the electrocautery enhanced tip. We're going to preload the delivery system with a guide wire that we can immediately advance after we've entered into the small intestine. We're going to probably push the stent out of the sheath versus retracting the sheath because we have more limited room here. So we're going to modify the technique slightly. And you can see there's a lot of contractility, but hopefully the glucagon's kicking in. Now you see it filling up very nicely with water. So let's take a look here. We'll just sort of freeze our image. And you see we don't have a lot of room, do we? Right? We're looking at just 2 centimeters. And you need to advance the sheath, the AXIOS sheath, 3 centimeters. At least 3 centimeters if you're going to release the distal flange by pulling back the sheath. So if you don't have that room, then you need to use the alternative technique of advancing the AXIOS out of the sheath versus retracting the sheath. That's what we're going to have to do today. Unless I can find a segment where I have more room to advance the sheath. And of course, if we were coming from the opposite direction, that would work, right? If we were coming from this side, we actually would have that room, but we don't have it coming from the right side. I can pull back a little bit to see if maybe there's a better spot, but I think this is as good as it gets. You can just take another moment to see if there's a better spot to go for. We have choices, right? You can see there are multiple loops of bowel here. Now this is another, but this loop of bowel, you see there's a little bit more distance between this loop of bowel and the bowel wall, the stomach wall. What I do like about this is that our wire then, if we advance it, would go in the direction, and we have a little bit more room to advance the stent. So I'm inclined to actually go with this position, even though we have a little bit more space, right? This is more adjacent, but less room. It's all about choices here. More adjacent, less room. Here, less, a little further away, but a lot more room. I like this better, right? So if we actually then make a measurement, this is how we'd like to, we've got 3 centimeters. That's already good, right? So the further that we can advance our sheath, the better. Okay, now we're ready to advance the AXIOS sheath through the working channel. We have wiped off the outside of the sheath with some water. This is a hydrophilic coating, so it makes it nice and slippery. So it advances very smoothly. We are now going to use the swivel lure lock to lock this in position. All right, now we are going to, and if you could see here on the camera view, we're going to unlock here so that we can advance our sheath forward, and we want to see the direction that we're coming from. And I'm advancing the sheath out, and what's very key is that you never advance against resistance, right? So, and I just did encounter some resistance. If you encounter resistance, you've got to back off to straighten the scope so that the sheath comes out very smoothly. So now I'm pushing again, and I'm getting resistance again. What that means is that the tip is angulated and preventing me from advancing the sheath out. So you can see here I've got recoil, right? It's not coming out. So what I'm going to do is I'm going to just pull the scope back into a more straight position. This is very important. I want to emphasize this, that you do not advance the AXIOS sheath out against resistance. And I'm still having some resistance. And some of this may be the endoscope where it's kind of hanging up. If you see the endoscopic view, please, can you please put the endoscopic view at the bottom? Yeah. Or in fact, make the endoscopic view large. And you'll see here in the lumen, I'm trying to advance. So if you're looking here at the camera view, you see I'm trying to advance the sheath. I'm hitting up against resistance. And that's not a good thing. You do not want to, if you push against resistance, you may accidentally start to deploy the AXIOS. All right, there it just popped out, all right? So what you don't want to do now is pull this back. You can pull it back ever so slightly, but very carefully to make sure that you're not detaching. You see the black mark? You see the white ceramic? That's the ceramic portion of the bougie tip. You want to make sure those two always stay together. They cannot separate, okay? So as long as you pull back and they stay together, it's okay. So you can see how this tapers very finely towards the tip. There's a micro wire at the very tip. That's what allows us to gain access with cautery so nicely with minimal coagulation effect. You see here that our nurse is attaching our cable to make this hot, and we're going to be using pure cutting current. But first thing we need to do now is we have to find that loop of bowel that we were just looking at, and that may not be so easy, all right? We have to look for that again. This is actually pretty good. Can you hold this, please? We'll give a little bit more water to fill this up. So you can see that our distance would be, there's the tip of the Axios here. This is our target lumen. And we can also measure this out just so that we have an idea of the distance, right? So we're looking at about 1.5 centimeters to get in, but altogether, this is just shy of about 3 centimeters. I think if we push the stent out, we should still be okay. I have to say I still prefer this down here, but it's not as good of a, and it's already starting to contract there as well. Let's stick with this. See, the challenge with the small bowel is it's always, there's peristalsis, it's contracting. This I like, okay? And we have the option of always giving a little bit of water to help fill the room, and we'll just step on the fluoral just to confirm where we are, just in case we need to go back to fluoral image, okay? There's our fluoral. We've got sort of make a mental note. I want to see, there, you see the Axios tip? I really like this position. I think we're ready to go. It's hot. We're going to use pure cutting current. I really like this position. We're ready to go now. And so if you can see on the camera, all I'm doing is advancing the sheath forward, and I'm going to step on the cautery. I'm going to give a little bit of cautery for a little bit before I go in. And now I'm in something. But before I do anything, I've got to see where I went into. By the way, here's our wire preloaded, and let's see on the fluoral, let's have the fluoral big. We're going to advance the wire to see whether we're inside of the small bowel. All right? And let's change please get it centered, please, better, so that we can look. You got to bring it down a little bit, the x-ray, and then we're going to very, very cautiously advance the wire. Okay? Can start to advance the wire and see. Ah, we definitely are in it. Look at this. This looks beautiful. Okay, did you see that? We have a nice cross section. And the good news is I think we're able to get our sheath in pretty far. Now we are still going to push it out rather than pull the sheath back, just as a precaution. You'll leave the wire in. And the way that we do this is we have this, is this unlocked?
No, it's locked.
Okay, unlock it, please. So this is on the opposite side. We're going to keep this stable, and I'm just going to advance this part. So let's look on the EUS image as I'm doing this. This is unlocked. I'm sorry, can you unlock this? There it is, unlocked now. Okay, and this I'm keeping stable, and I'm just pushing this forward. That's pushing the stent out, pushing the stent out. I'm going to pull back the sheath just a little bit. Ah, we're good. Excellent. So the stent deployed a little further down. That's why I didn't see it. It was sort of at the bottom part of the image. It looks really good. See? I'm pulling it back. I'm going to snug up. This is the small bowel. I'm snugging up against the wall. Okay? Good. Now I'm going to lock this. All right? So just so that you can see it, it's locked position. So this is the advantage of the swivel. I can just swivel it towards me and swivel it towards you. We can both enjoy the view. All right, now we're ready. It's locked. I've now locked the sheath, and now I'm going to deploy the proximal flange. Now, you see we have a red out, but I'm now going to give some air, and what I'm going to do is as I'm backing off from the wall, let me just check this is unlocked. So this is unlocked. As I'm backing off from the wall, look at the endoscopic image. You can see the end of the stent. I'm pushing it out. I've pushed it out, and to push it out completely, I advance this gray hub here like this. All right, so now it is deployed. All right, here we are. And you're looking inside, and the question is now whether we're inside of the peritoneum or inside of the bowel. And of course, we're hoping this is inside of the bowel. And when you're in the peritoneum, usually the first thing you'll see is omentum. You'll see some fatty tissue. I'm not seeing that, so this looks promising. All right, so we're going to leave the wire in place, and I'm now going to remove the delivery system. Okay, so I'm now pulling back. There we go. I am very optimistic. This is looking very nice. But before we do our dilation, I want to just confirm that we are nicely in the small bowel. And to do that, we'll just take our catheter now, our ERCP catheter, and we're going to guide that over our wire, and we'll put a little contrast in. All right? Ready to inject? Injecting. Yeah, this is small bowel. Good. We're ready to dilate the lumen. We are in the small bowel. And we're leaving the wire just there. I want you to advance the CRE balloon 12 to 15, please, over the guide wire. There's a nice view. Why don't you make the EUS large? You see the AXIOS stent now very nicely in the small intestine. Looks very nice. Watch the wire, please. Going down, we'll just put this in under direct endoscopic visualization. There it is, in great position. Advance it a little bit forward until we see the purple mark. There's the purple mark. Dilate up, please, now. That's good. And that's all we're going to do is the 12 here. Just hold it for a second. Let it kind of really go up there. Wait till the fight stops, and then we'll go back down, okay? We don't want to go up to the full 15 because we don't want to do anything that would risk that the stent could dislodge. It's unlikely. But now you have a beautiful view, right, of the distal duodenum / jejunum. No need to go through with an endoscope to convert it. It looks beautiful. This is a great outcome for her, and I think this is going to give her wonderful relief of her symptoms of gastric outlet obstruction. She's been miserable. She can't keep anything down. She's constantly nauseated, vomiting, and her saliva is literally pooling out of her mouth. I think this is going to be great. We can pull out everything right now, including the nasal luminal catheter. I'm going to check on her a little bit later today, but as far as I'm concerned, we can start her right on liquid. The AXIOS stent is going to give her the relief she needs for the quality of life she deserves. Thank you.